My name is Anjay Rastogi. I'm a nephrologist. I'm also the medical director of the Living Kidney Donor Program at UCLA. And today we'll have a very interactive program with Q&As on living kidney donation. This is a follow-up to our previous program that we did with Ms. Durbin on the wait list for kidney transplant at UCLA. Now, before we get into the slide deck, I just want to go over our core kidney program. This is what we stand for. It's a multifaceted, multi-specialty program that we provide at UCLA to provide the best care to our patient with kidney disease, starting from preemptive or pre-diagnostic workup to transplant. So the entire spectrum is including clinical research that we do, dialysis, home dialysis, everything. So if you haven't been to our website, please do that. You'll find a lot of information, also some comments, and this is our contact information, including our email and a direct phone line, which is 310-954-2692. So with that, I just wanted to introduce our kidney transplant team. Dr. Danovich, Dr. Gabe Danovich, my mentor, who is the medical director for the entire transplant program. Dr. Albin Gritch, who is the surgical director for the transplant program. Dr. Jeff Veal, who is actually the director for the peer exchange program at UCLA. Ms. Dunbar Forrest, who is our transplant manager. And then their entire faculty, staff, and coordinators. We're very grateful for the service they provide to us. And saying grateful, today I have my colleague, Miss Suzanne McGuire, who is a nurse by practice, and everybody knows how much I like nurses, and they provide the nursing care, but she is also the supervising person for the living donor team with a wealth of information. And we're very privileged and honored to have you, Suzanne, over here.
Thank you. I'm pleased to be part of providing more information for potential living donors and the recipients who are looking into the need for a living donor.
So Suzanne, how long have you been doing this?
About 18 years. I've been a nurse at UCLA my entire nursing career. I started in the liver transplant ICU and then moved over to kidney transplant 18 years ago.
And I heard that you were honored recently. So what was this honor about?
Well, we were part of a celebration for 10 years in the National Kidney Registry as part of their original paired exchange core teams. And we did the first transcontinental paired exchange flying by commercial airline in 2008. And so it was a celebration for our 10th year.
And I missed that because of some personal reasons, but so anyways, Suzanne, that was great. And you mentioned something about peer exchange, which I do want to dive into a bit more, because there is a lot of confusion that who can be a donor, who cannot be a donor. So I think the peer exchange will be going over in a lot more detail. So today we'll have a lot of questions, and this is a live program. So if you have any questions, please feel free to put them in, or you can actually even do it after the program as well. We have a lot of questions that came before the event, so we are going to go them one by one, and if we can't get to all the questions, we'll answer them at our follow-up program that we'll be doing pretty soon as well. So with that, let's dive into the questions. First question, which is a very broad question: who can be a kidney donor?
We actually get this question quite a bit, and the answer is fairly simple. If you are healthy and you are willing, and you are of an appropriate age to be a kidney donor, you may be able to donate on behalf of a loved one, and it's as simple as that. It can be more complex.
Right. Very good. So so if they feel they're medically and psychosocially into some of the factors, which will be going in a lot more detail, they can be a kidney donor. And you did mention one thing, loved ones, but there's also what we call the non-directed donors, or what we call the altruistic donors, and they also love someone, they just don't know who they love.
Yes.
So we'll be going over that as well. The non-directed, we used to call them altruistic donors in the past. I think everybody's altruistic who goes through this process.
True.
So who can be a kidney donor? The next question is, how do I, so there's a person who has thought about this, and I always tell our people who want to donate kidneys that they should give us time and thought and read about that as much as they can, but be careful what information is out there. But contact a site like UCLA that we can give you more information. But once they've made up their mind, they say that now they want to apply. So how do they apply for a kidney donor?
Well, we have an online donor application, and we will provide you with the URL, the address to type in, when you want to go online and apply as a donor. All of the applications are reviewed by a registered nurse, one of the living donor coordinators, and then the patient is contacted to go over the information that they've provided and obtain additional information as well.
So it's an online process.
Yes.
So they will need a computer and internet.
You will need a computer. Please do not use your cell phone. You can use a tablet, you can use a laptop or a desktop, but the formatting of the application does not work well with cell phones. So please don't try to fill it out on your cell phone.
So I think, and this is different from what we did probably just about a year ago, right? I mean, how long has this process been?
We've used an online application for about a year and a half. Okay. Prior to that, all of our applications were done on paper and either mailed in, brought in, or faxed in. This is a much better way to have the patients fill out the information and screen certain things in and certain things out. Sometimes people are screened out by filling out the application this way, and it provides them with reasons why they may not be able to be a donor. And if they have questions, there's a phone number for us that they can call.
So it's an online process, and so far it's only in English.
That's correct.
So if English is not their native language or they can't speak, they will probably need to get some help in filling out the forms.
Yes, if you are not fluent in English and you need help to complete the application, please have a family member or a friend who is fluent in English help you complete it online.
Very good. So one term that you use is screened out. And I will be going over that over and over again. So one of our main purposes of the Living Donor Program, and we separate the living donor and the recipient programs completely. And this is coming from our directors and leadership, Dr. Gritch and Dr. Danovich. When I was appointed as the medical director of the Living Donor Program, they wanted the two programs completely separate, so that there's the purpose is it's a donor-centric program. We want to do as much as we can to make sure that the donors will do well. I mean, we don't have a crystal ball, we can't predict, but based on what we have now and their family history, you mentioned the significance of family history. That's something that we do focus on. We can see what is the risk of a person having kidney problems themselves down the line. So we do spend a lot of time. We used to call them the intake forms. We go over them, and it's not just the nurse sometimes, or they also get the medical team involved if they have any questions to see if that, and if we think that the person is at high risk of having kidney problems themselves, we will send them a letter or email or whatever the way of contact is, that these are the reasons and they should. So this is the first step. This is just the intake form, and a lot of people might be screened out if we think that they're at risk. We one of the policies that we have, and it's been ingrained, is that we don't want to put the donor at any risk. Sometimes there's absolute risks and sometimes there's relative risks. So the absolute risk, then obviously the answer is no, but there's a relative risk, and we'll come to that we can work through them. So they've gone through this intake form. It is online. It is in English, right? And the nurses, the coordinators have gone through these questions, and then the next question that we ask is so now the evaluation process starts. So the transplant program is going to contact this potential donor.
Yes. Sometimes there are multiple applicants for a specific recipient. For example, if it's a person who has a number of siblings, family members who are interested in being tested for donation, we will do compatibility testing on more than one person at a time. What we usually do is 3 people. Not everyone is lucky enough to have 3 people who are interested or able to be a potential donor, but we will test 3 people at a time to see how close a match they are. Sometimes all 3 are a match, sometimes none of the 3 are a match. And if that's the case, then we will test more donors. We often will have someone who had some sort of a media blitz where there are a number of people who have submitted applications and they are interested in helping that person. So we have to go through a screening process with them and try to find out which people might be most likely to proceed. So we want to make sure that we're doing what's best for the donor. People sometimes have other health problems that they don't realize might be problematic for them after donation. It's also important that people have good social support. This is not something to go through by yourself. It's very emotional, it's very exciting, but there can be sort of a roller coaster journey when you get test results that you don't understand and things need to be explained to you. So it's important to have both social support and to be healthy and have family members and friends who believe in what you want to do. All of that is part of being a donor and having a positive experience. So we start out the process of interviewing the patient who applies to go over their family history, their own health history, who it is in their life that they identify.
It's more deep dive into the intake form.
Yes. Right. And then if we're going to move forward with testing, then we arrange for testing. Sometimes we need to do pre-screening testing that may need to be done before they're brought into UCLA for evaluation. If we need to do that, we'll let the patient know what they need to do. For example, if they have a strong family history of diabetes, they may need to do some testing at a local lab to see what their risk for diabetes is right now. As you mentioned, we don't have a crystal ball, so we wouldn't be able to assess their risk for diabetes 10 years down the line, but the idea is to assess what the risk is now. So if all of that pre-screening comes back and it's within normal limits, the doctors feel that it's safe to proceed, then we would schedule their evaluation at UCLA. We try to do that within a couple of days' time if we can. The time frame is dependent on available appointments, the patient's availability, their own schedule, and what works best for them. It involves consultations, a class with the donor coordinators to explain the process, lab work, several diagnostic studies, chest x-ray, EKG, a CT scan of the kidneys. So it's important to know if patients have an allergy to contrast. Those are things we need to know ahead of time.
And that you'll be asking them when you
yes,
call.
And that's one of the questions on the application.
And one of the points that I do want to mention is that please provide as detailed history as you can.
Yes.
Like what medications you're taking. If you had a surgery in the past, what kind of surgery it was, especially if it was abdominal surgery, the surgeon would want to know that. So, and if you forget that, that's fine. Sometimes, there are things that you forget, but if you remember that, and once again, I spoke that when Bethany was here and we were talking about, but your coordinator, so they'll be assigned, so they'll be assigned a coordinator,
yes.
Right? So, and suppose Suzanne is their coordinator. They should know, and this is once again very critical. Once your case is opened up, now you're in direct communication with the transplant program, you will be assigned a coordinator. And that, once again, I'll repeat, is your quarterback. That you should have that person's name and number. And do you guys contact via email as well, or?
We can.
Okay.
We also encourage our patients, once they're encountered into the UCLA system and they're brought in for their appointments, to apply for My UCLA Health, so they have access to their chart.
Yeah, and I think that's important because My UCLA, it's much more secure, and that's the reason why we want that. MedNets are secure as well. But the push is at all the big programs is to use a much more secure system. So My UCLA Health will be the best way. But keep in mind who you're coordinating, because that is very critical. That person's name should be on your or whatever you like to do.
One of the things that's important to know is that if we call the patients, they won't get on their cell phone, it won't show our direct number. And so sometimes people won't answer the phone because they're getting a generic number.
Right.
So if you see something with a 310 area code, 825, that's us.
Right.
So please do answer the phone if we call you, and if you don't, we will leave a voicemail message. It may be a generic message if we can't tell that it's if it's a generic response. Yes.
Right. So they've gone. So we have did the intake. We have an in-depth interview with them, and now we're bringing them. And you mentioned that it's a pretty. So once again, it's a safety for the patient, for the donor. We really want to make sure that we do our best. Once again, we don't have a crystal ball, but we try our best to assess their risks. First of all, do they have problems? And a lot of times we find out that they actually have problems.
Yes.
And we'll discuss that as well, because that's also important, that they can't be a donor to start with, but they have their own medical problems that they should be, because a lot of the people are quote unquote healthy, and they think that they have no problems, and then we do some more testing, and so that's, in my way, it's additional benefit you can call, but they can find the disease early on and address that, and we go over that in a lot of detail as well. But we try to pack them in 2 days. They see the medical person, which is the nephrologist, which is me or my colleagues. They see the surgeon. They obviously, the coordinators are heavily involved. They undergo a psychological evaluation. That's very important. And Suzanne had mentioned about how they feel, and it's could be an emotional roller coaster. We have seen that, so it's very important to have a support system as well. But we do provide full psychosocial. Our social worker also does an in-depth, and a name that I want to drop is the ILDAs, the Independent Living Donor Advocates.
Yes.
And the term advocate is that there is, every transplant program assigns an advocate, and that person is an advocate for the donor. And not too long ago, the nephrologist used to be and that includes me. So we were, as a medical director or as a nephrologist, we were their advocates. But we all are advocates, by the way.
Yes.
All of us are advocates. But there is an assign, and this is a requirement by UNOS or
and CMS. Yes.
And CMS.
And the reason that there is a donor advocate independent of the recipient team that is assigned to the donor is because we know that this process can be very exciting for recipients, and that's why we have to keep things separate. So we need to protect patient confidentiality, we need to protect the interests of the donor, and sometimes the donors feel strongly that they're either being pushed into donation, or maybe they really, really want to donate, and we're finding on their studies, all of their exams, that it may not be healthy for them to do that.
Right.
So there have been times that the donor advocate intercedes to explain to them, along with our explanation, that there are reasons that it's not a healthy thing for them to be a kidney donor.
And I think that's very important. So the purpose of this ILDA, and that's the other person's name that you should have. You should have your coordinator's name, and you should have the ILDA's contact information, and feel free to reach out to them anytime. Mara is our ILDA here, and she's absolutely fantastic.
Yes.
She was actually a social worker in our dialysis program before she became the ILDA. So we are very fortunate to have
And that's
her as
valuable,
well.
because
It's
she
very
understands both sides of
Both
it.
sides, yeah.
She understands what the recipients are going
Right.
through. She understands what the donors are going through.
And I think the other point that Suzanne mentioned is that we don't want any pressure, any kind of pressure, whether it be psychological pressure or getting the labs done. So if you do feel comfortable, it should be at your pace. I mean, that's,
Yes.
I always tell our living donors is that they should take time. It should not be something that they just woke up in the morning and say, you know what, talk to other donors. We have provided contact information as well,
Yes.
so they can talk to other donors who have gone through the process already, and see what it's like. And we try to match them with the same age group and same as close a match they can be to that person. But do talk to your ILDA if you need to, and obviously your coordinator is your quarterback once again. So a lot of people say, and they say that we have 2 days here, and it's so intense and stuff. And the reason why it's intense is that there are tests that are to be done. There is blood test, there's urine test, there's a CT scan, chest X-ray, EKG. They see the nephrologist, they see the surgeon as well. Sometimes the same day, sometimes they're called back. So it is, but we try to put everything within those 2 days, so you don't have to spend too much time coming here. So that's the purpose. And so we could have drawn out the whole week. So
Well, and we do have patients who sometimes they can only be off maybe 1 day a week.
Right.
So sometimes they ask to spread their
Right.
evaluation out. There are people who do need time between their appointments. They need to consider what it is that they're wanting to do. And so it's important for us to sort of work together with them and partner in scheduling their evaluations based on their needs and what we're able to accommodate for them in clinic.
So you've called the donor. What's the average wait time?
Well, we
Provided
try to
that the
see.
donor is available, because obviously you try to accommodate them if it's
Yes.
down.
We
But
try to see them we try to bring them into clinic. If all of their, the intake information, any pre-screening they've done, if all of that looks okay to move forward, we try to bring them in within the next 4 weeks. Most of the time we can do that. Sometimes if our clinics are full, we have to space it out a little farther. Sometimes patients want to wait and come
Right.
based on vacation, time off work.
Right, and the other thing that I do want to mention, you had mentioned some pre-screening labs too, and diabetes and hypertension are the two most common causes of kidney disease in the U.S. But if they have some chronic conditions that are stable, for example, if they have thyroid problems, they're taking thyroid supplements, it would be a good idea to go and visit your primary care physician and get an updated,
History and
labs
physical,
and stuff,
yes.
because if there's something, so
Yes.
that will save you time down the line as well. Because we
Yes.
will be telling you that in any case that we want, unless you're at UCLA, because if you're at UCLA, we have access to all your records, so we can look it up. But if you are not UCLA, I think it's very important that you go and see your primary care. And even if you're at UCLA, it doesn't hurt to see your primary care physician before you come and see us, so that we have those basic labs and we can give you some guidance about that as well. So I think all this is to expedite the process itself. So they've gone through this two days of quote unquote, we keep them busy,
We
I mean,
do.
and but not too many people complain at the end. I mean, they might be a bit tired, they might be fatigued. We see them quite a bit, I mean, every week, and I think because they can see all this is going towards a good end.
Yes.
and helping somebody that they love.
Yes. And it's important that we try to layer the information so that they hear a lot of the concepts more than once. That way you are given information that you're able to absorb and think about and make sure that this is a process that is going to work for you. It allows you to think about how this may affect your family, time off from work, and your own health going forward. And so once you've been evaluated, it takes about 1 to 2 weeks to get all of the results. And then we will review that as part of our multidisciplinary team meeting that we hold every week or every other week. And all of the results are reviewed to make sure that everything looks okay for the person to be able to proceed with donation, both psychosocially and medically. And we look at the films from the CT scans, and if there's any findings there that are concerning, then those are carried back to the patient with recommendations for either additional evaluation if necessary, or if they're cleared, we let them know that. Or if it turns out that they're not able to proceed as a donor, we would let them know why. We would provide you with all of the results if you can't move forward and explain what the evaluation means and how you need to follow up with your primary care physician.
So let's talk about this donor selection committee that we call the multidisciplinary team. And in this team, there's a medical director,
Yes.
which will be me. There's the surgical director, Dr. Gritch, and then all the coordinators and all the
Yes.
evaluating nephrologists and the cycle. So the whole team gets together. But before we get to that meeting or the case is presented, there's a whole, all the labs are being looked at. Everything, all your workup and your history is assessed by the coordinator. And if they have any questions, they will ask the nephrologist or the surgeon who saw you and ask them questions and see how we can do that or how we can address that. But so even before so I always put them in 3 big buckets. They're people who, by the way, all cases get presented to the committee.
Yes.
So every single case that will eventually lead to a surgical process are presented to the donor. But one group is the one extreme is they're perfect candidates. There was no issues that we could find, and it's pretty clean, and they, as long as they want to donate still. I always say you can always say no in the entire
Yes.
process till the kidney comes out. So after that it's a bit late. But before that, if you have any doubts, we obviously would not like it like right before you're being prepped for the OR but you have a right to say that. You can say no, that I don't feel comfortable, and that's completely fine. And we stress that on when you come for this should be an enjoyable experience as much as it can be. So the one bucket is that they are perfect, and as long as they get cleared and we get a surgical date. The other end is that they actually have medical problems that will preclude them from being donor ever.
Yes.
So they are at risk. It could be a different kind of risk, but they're at risk, and they are. And like you pointed out, for these patients, we do reach out to them. It's not just we just say that you're not a donor. We give them resources that they can go, who they should contact, and either way, if you are accepted or declined, you should get a copy. I mean, I always tell them to get a copy. And do we send?
We send copies for patients who move forward with donation.
Yeah.
We wait until after the surgery so
Right.
we can
You
send
get
them the
everything together,
entire
yeah.
packet. Yes.
in the piecemeals. But the
Yes.
people who are declined, we
Yes.
send them a note, and we also tell them why they declined and what they need to do to keep themselves healthy.
Yes, that's
and depending
correct.
upon how bad it is. I mean, if they have uncontrolled, we have seen uncontrolled diabetes. We have found cancer sometimes,
We
right?
have.
And so we try to address that. So those are the two extremes. But a good portion of patients fall in the middle.
Mhm.
In which they can be donors, but they're not there yet.
Right.
and that's where that it depends upon how far they are. We also talk to them if they even want to be, because there might be additional risks. There might be lifestyle modifications they might want to do. They might get on some treatment for their illness. So those becomes and that might sometimes. Because my next question would be, is once they present to the donor selection meeting, and the fair question would be the patients who are approved, because the patients who are not approved yet, they will be delayed, because they have
Yes.
to, and sometimes 3 months, sometimes 6 months,
Yes.
sometimes
Sometimes
years.
longer. Yes.
Yeah, because if there's something we find a lesion on their CT scan
Yeah.
that we don't know, we probably will put them through a couple of years of follow-up, and we'll give them exact guidelines. But suppose a person is presented and they're clear, the donor selection puts a stamp on it that you can. How long is the waiting time for the surgical?
Well, after we've presented the case and the patient has been approved
Right.
as a donor, we contact the donor. And if we can't reach you, if we get your voicemail, we will leave you a message, but we will not proceed with requesting a surgery date. We will not talk to the recipient to say your donor is cleared until we've heard back from the donor. And a lot of times when we speak with the donor and we tell them that they're cleared, they like to tell the recipient themselves. It's a very exciting time. It's great news. And so we want them to have that joy in telling their recipient that they were cleared. And then once we know they're ready to go, which they need to tell us, at that point we request a surgery date. So it's possible that once the donor is cleared, we can have a surgery date within 6 to 8 weeks. Now that is impacted by a lot of factors. Number one, how full our surgery schedule might be. Number two, whether or not there are any issues with the recipient's insurance, because that's where the payment comes from for both the recipient's transplant and the donor's surgery, is from the recipient's insurance. So there might be some pieces to that have to be resolved. And so that every now and then can cause a slight delay in scheduling surgery. Sometimes they can have surgery within 3 to 4 months of being evaluated, depending on if they fall in that bucket, as you say, where they're perfectly healthy, nothing has to be repeated. The average time from the time they apply to when they're ready for donation and able to have a surgery date is about 6 months, but it can be a year or longer, depending on their readiness, depending on the recipient's readiness. There are a lot of factors. Mm-hmm. So we have people who come into the process and they donate within 3 or 4 months, and then we have people who donate a year or later.
So on average, it could take at least about 3 months, 2 to 3 months.
Easily. I would say it's closer to 6 months for most pairs.
Most pairs, and it also depends upon what time the donor has, the recipient, and all those things. But once they're clear, then you say about 4 to 6 weeks they can get, depending upon the availability of the OR.
Yeah, 4 weeks would be pushing it.
Yeah.
Yes.
Yeah, good. So they've gone through all this process. We have communicated with them. Then they've gone to the surgery, and then we'll come back to that as well. Let's see what the next question is. Age limits. So
this is a good question. You need to be at least 18. You have to be a legal adult to apply as a potential donor. All of our donors over age 70, we need to evaluate very carefully, because they're getting older. That means their kidneys are getting older. So we have to look at things carefully there. However, for our patients who are between the ages of 18 and 25, we look at those patients very, very carefully, because they're just getting out of high school or they're in college. They're just getting started in their adult life, establishing a career, establishing their independence. And so there's a lot of factors with that may play into their readiness to take really good care of themselves if they donate, to understand the respect they need to have for their body if they've given away a perfectly healthy organ. We want to make sure that they have a good, strong social support system. And we also have to think about the relative risk of let's say a 20-year-old with a family history of diabetes donating and living a very long life with one kidney and an inherent risk for a disease that can affect their remaining kidney. Whereas if we have a donor who comes forward who's 55 with a family history of diabetes and they're healthy now, their diabetes screening test shows a low risk, that person's risk of developing diabetes is quite a bit lower.
So they had to be at least 18.
Yes.
But like you said, and this we did recently. This is a discussion so we do all these internal discussions about how to improve, just outcomes for our patients. And one of the things that we did is if you're between 18 to 25, they had to be presented to the committee
Yes.
before we can work them up. So this is we definitely like to avoid any younger than 21 as much as
Yes.
we can. But if they're younger than 25, the case will have to be presented to the committee, and this is once again to protect the donor.
And I one of the things I wanted to say about the example I used for diabetes, donating a kidney would never cause you to develop diabetes.
Yes.
It's simply that it's one of the diseases that we know creates a risk for kidney disease. And if you have one kidney instead of two, and you have a family history that creates a risk for kidney disease, that's how we're thinking about that.
We're trying to think as far down the line, and also diabetes does not cause ESRD in majority of cases overnight. It takes
Correct.
10, 15, 20 years sometimes to actually diabetes as a direct cause of ESRD. So we're trying to project as much as we can, and that's why we feel, and I think the best age group, like you said, is about in the 50s or 60s when things
We love our older donors.
But when you get a bit above 65, 70, then
Yes.
and I know when I had just started the living donor, anybody over 65, we would just decline them. And it's not just because of kidneys, but also because of the cardiovascular, the mechanical things. You have to go through the surgical process in the OR. I mean, that puts a lot of stress on your body. So that needs to be taken into account, even though some people come, and I think the oldest we have done is 75.
I think that's about right.
Yeah, but that's really
about
pushing
right.
it.
It is pushing
That's
it.
really pushing it. I
Yes.
personally don't feel comfortable once they're 70, but we do case by case basis.
We do case by case, yes.
And-
Those
and-
are reviewed also before we
And
evaluate.
pretty intensely reviewed. I mean,
Yes.
we have a pretty, intense discussion at those meetings about, once again, about the safety and concern about the donor.
Yes.
So that was who's too young or too old. Now, and I know we're running a bit out of time, but just briefly about this match, because and what I would like to just get the audience is that you don't have to be a blood group match, and I think that's the key point to take home today. Is there is, and you had mentioned the paired exchange program.
Yes.
So if you are not a direct match for blood group, there's also an HLA typing, which we'll discuss in the next, because I know we're running out of a bit today. But if you are not a blood group match with the recipient, you can donate to the paired exchange program, in which and the chain program starts and stuff. And we'll be going over that in a lot more detail in the next program. But something definitely keep in mind: the blood group incompatibility should not preclude you from donation.
Correct.
Yeah.
It's no longer an obstacle.
An obstacle.
Yes.
Who pays for my workup and the surgery?
The evaluation is paid for by UCLA through the Medicare cost report. So there is no cost to the donor for evaluation. And in fact, if you receive a bill in error, we would want you to send that right back to us so that we can correct that. The surgery itself is paid for by the recipient's insurance.
Okay. So there is no direct cost to the
donor, no.
Right. So I think that's, and if by mistake you do get a bill, just make sure that you send it to the transplant program, and they will take care of it right away.
Correct.
Can I get compensated for my kidney donation?
It's illegal to be paid or to pay for any type of organ transplant or organ donation in the United States. It carries a hefty fine and possible jail time. So don't expect to be paid for your donation.
And I'll just link it to my other question would be, which we get asked, should we get transplant in other countries? And I just think that you have to be very, very careful, because first of all, find out if it's even legal in that country. Because if it's illegal, then there is no oversight, right? So and we have seen the
results of that.
Results, and,
yes.
and I want to say the Rex, but it's the results when they come in and with infections and stuff, and it's just a mess. It's not a pretty scene. So just be careful. I mean, very cautious. Are there any funds? So there are no direct costs, but they're indirect costs. They can't work for that time, or their flights are there, or hotel, or you said childcare, right?
Yes, childcare, time off work if they don't have vacation or sick time. So there are indirect costs to the donor, because they need to take time off work. They need someone maybe to care for children. If they need to travel from out of state, they might need a rental car. They might need gas. Obviously, meals for the period of time that they're with us for evaluation. So for recipients who meet income criteria, there is funding through the federal government for the National Living Donor Assistance Center. It's called NELDAC for short. Their website is livingdonorassistance.org. That's all one long address. And the recipients can go to that website and look at the worksheet for income to see if they meet the criteria so that their donors' costs could be covered by funding through that grant.
And we provide that information when
we do. We provide that information.
You get all that information from your coordinator.
Yes. For patients who live close to our transplant center, the expense is usually just gas to get back and forth. We do provide parking vouchers through a grant that a very grateful patient provided to offset some of the donor expenses. And if we are able, at the time that they donate, we provide a hotel stay for the short period of time that they need to be at UCLA, and their caregiver would be able to stay with them.
Very good. So we spoke about this already. Because of time's sake, we have multiple steps in the evaluation process.
Yes.
We have the ILDA, the advocate, we have the coordinators, we have everybody in the team. Actually, the donor team is separate from the recipient team, and I think I want to re-emphasize that. And I have a big dialysis population myself. So if we have how long does the workup take?
We did talk about this.
Yes.
Yes.
So I think we can pass this. Now, this portion I think we should discuss at the next one.
Okay.
So today was just more about evaluation. So if you have any questions about that, then we'll be discussing. So you've got to the surgical process. Now you're in the OR, and what's post OR. We'll discuss that at our next. But before I end today's program, I just want to give some information. This is the transplant team information. This is the direct line. This is the online application that Suzanne had mentioned. It's www.uclakidneydonor.org. And if you email us, then we can send you this information as well. But I want to end with two slides. One is our kidney fair at Santa Monica Beach. This is May 5th, Cinco de Mayo Day. And this is from our previous event. As you can see, everybody's very happy and thrilled to be there. And they were in green, which is green is kidney color. But this year's is going to be very special. And what we are planning, and Suzanne and I have been talking about this for quite some time, is we're trying to get all our past living kidney donors at the fair to honor them. So you'll be hearing a lot about this. If you know any living kidney donors, ask them to contact us. May 5th is the date. There will be a big push to about education about kidney donation. So a lot of them were there at the previous event. There'll be a lot more at this one, but we really want to get to the number as high as we can, so all of them can be here and how much we support and appreciate these kidney donors. And last but not the least, I want to mention my very good friend Ravi Bhojwani, and this is Sarah Erskine. So this is his transplant anniversary. Just happened to be today. I'm actually going this evening to meet with them. So today is their one year anniversary. And
happy anniversary.
And Sarah actually was what we call the non-directed donor at that time. She and all the altruistic donor. And then she actually met with one of our other kidney donors, and one thing led to the other, and then she met Ravi. And Ravi, this is what we call a preemptive transplant. So Ravi never had to be on dialysis. He went straight, and as you can see, he's doing fairly well and doing. And he's a big proponent of kidney transplant, and he was one of the key members who started a Green Ribbon campaign. So once again, congratulations, Ravi, and Sarah is an angel, as you can see. So with that, thank you so much for joining our program today. Suzanne, thank you very much for being a true partner in our kidney transplantation, and we worked for such a long time. We'll be having a few more of these actually as a follow-up. We'll have also with Bethany, we're going to have a follow-up for the waitlist. We had got a lot of questions. We couldn't answer all the questions. As you can see, we couldn't even answer the question that came in. But if you have any questions, please feel free to email us to still put them on whatever online process you're on at this point, and we will try to answer them at our next program. This program is recorded and will be on the website, and will also be on UCLA YouTube, so you can look at it again. And also there you can ask questions because our UCLA team follows these programs on YouTube. If there's any questions that are posted, we will incorporate them. And once again, I do want to thank all our living kidney donors. And it's not just people who have gone through the process, but anybody who thought about the process.
Yes. It's
a priceless gift. It's a gift of life that you're giving. And also don't forget the deceased kidney donation. Living kidney donation is obviously amazing, but you can help a lot more by deceased. And I forget the number that one person can influence 72 or it's an amazing impact that one person can have. So please don't forget about signing up for disease organ donation as well. With that, thank you very, very much, and once again, thank you, Suzanne.
Thank you.
And we'll see you soon. Thank you very much.